Hi, Dr. Dave Webster, and this is part of my ongoing video blog series on the travesty of patient access to PET-CT in our liberal so-called evidence-based patients first healthcare system. And this is part of a case series that in this case related to patients with possible lung cancer or known lung cancer cases, and I want you to consider whether we should be calling Dr. Eric Hoskins our Minister of Health or our Minister of Disease. So this is part two of a two-part series looking at Dr. Hoskins's agenda for our lung cancer patients, and it's entitled Unnecessary Assaults on Patients with a Lung Biopsy Needle. This first case I'm going to ask you to consider on that. It's case number 2 in the series. But an 83-year-old female, she's had a recent chest x-ray and then a CT actually for chest, abdomen, and pelvis, which was a large mass in the right lung apex or upper lobe, which is highly suspicious for lung cancer. And the only other findings on the CT exams were a small nodule in the right lung inferiorly. Now, cancer care forced standards on her physicians say that the patient must have a biopsy before her PET-CT can be ordered. But her doctor's going to play the system a little bit, and as long as they've ordered the biopsy, they can go ahead and book the PET-CT because they want to minimize the wait for the patient, because this really will be the critical test, as they already know. I want you to keep in mind is that we have about 14 PET-CT cameras in Ontario, but we're only allowed to do approximately 800 patients per year, whereas if we look right next door in Quebec, they use PET on the average of nations that offer PET for their patients routinely, and they also have about 14 cameras, but basically half the population of Ontario, and they do roughly 3,000 patients per camera per year. So this is the cross-section of the CT's chest. This is the large ugly mass in the right lung, left lung here, the airway. Now this patient I'm just showing the position of the biopsy needle in this mass. Now the patient's actually lying on their stomach, so this now is the right side of the chest. These are the patient's bones in their hands right here and their right shoulder. So the patient is lying on their stomach for this. But the point is that biopsy comes back negative. Now, how could it possibly be? We do know the patient actually does have cancer. Certainly the PET did show that clearly, but the biopsy is negative. They don't have any tissue yet. So here's the PET-CT, and as you can see, the needle is not in the active part here. It is in scar tissue. This actually was cancer at one point, but because of lack of oxygen, these cells have died, and this is simply scar tissue. But remember, the radiologist has no way of knowing without the extra information from the PET scan. It is only the PET scan that can show you where the active part of the tumor is and where you should put that needle. But as the patient, remember this frail 83-year-old lady lying on her stomach getting this big needle stuck in her back, what happened to her actually. She's a smoker, she's got bad lungs, the needle punctured her lungs, and she has an air leak, a pneumothorax in her chest with a partially collapsed lung. This is black area, here's the air there. This little fader white area is the collapsed lung, and if we look kind of at a cartoon image, we can see collapsed lung here, and this is the collapsed lung here. That's the air in the chest itself here. So the treatment for this is they're going to have to stick a tube into that airspace and pull that out. Now, what I want you to keep in mind, of course, besides going through that traumatic biopsy as she's lying on her stomach, that big needle stuck in her back, this patient now, in addition, has experiencing significant pain and shortness of breath, not to mention anxiety and apprehension. So she will have a chest tube put in. Now, this can be done actually at the bedside, but the patient's draped here. They're freezing the skin with the needle here, so some stinging as that goes in. They make an incision, and then they stick an instrument in there to dilate between the ribs here, and then this is a chest tube it's now stuck through the chest wall, and it's sewn down to the skin, and this is all prepped up, and the patient will have that. Now, what we attach that air to, that tubing to, is this tube, which then is part of the process of removing that air from the chest over several days. So the patient's going to be in the hospital for several days until all this airs out, basically, and then she will not be completely recovered and symptom-free for at least several weeks. But remember, after going through all of that, the biopsy is actually negative, even though she does actually have cancer. The physicians do not have a cell type where they can actually partially customize what therapy they might offer for her, if any. So, but it turns out there's other things the PET-CT tells us that wasn't there on the CT reports, and this here is that little nodule down the right lower lobe. They commented on very clearly. This is of concern. May not be cancer, but almost certainly it is. And interestingly, this may be a spread of cancer from the right apex down here, but that has to go to the heart to get back to the lungs, and that would actually be a distant metastasis, making her stage 4, even though it's back in the chest again. Or in fact, as we often see in smokers, this may be an entirely separate second cancer. In addition, there are in the mediastinum, we've talked about before, at least in the middle of the chest, there are normal-sized nodes from the CT, but they contain almost certainly cancer as well. So it has spread. You can see there's a little bit of the cancer there. We're seeing it spread to this lymph node in the chest. Now, what else does it show? Well, these happen to be the adrenal glands. This is the left kidney. This is the stomach, with some contrast in it. This is the patient's liver. So this would suggest, with the uptake greater than in the liver and so on, that this may well be spread of cancer to the adrenal glands, a common spot for lung cancer to spread. But what else does the CT or the PET CT show us? And in fact, this is the patient's spine. Now, this is a vertical picture. This is the lumbar spine and pelvis here, but this shouldn't be here. There's probably a metastasis of cancer now into the bone in this patient's spine. But in addition, because we do scan the body, is that there's a potential for one more very critical finding, not uncommonly seen in smokers who have lung cancer, and that is that this is a cross-section of her neck, just where her vocal cords are, and you can see on the right side there's excess sugar here, and there's very potentially there might be a cancer that the patient doesn't even know they have yet. So let's go back to that report, though. Remember, the CT just talked about a large mass, the right lung apex, and the smaller one in the right lower lobe. None, and I say none, of these critical extra findings were seen on the patient's compulsory diagnostic CT with contrast. Now, some may be already aware from previous videos that Dr. Hoskins has chastised me. Dr. Webster, you should be concerned about radiation exposure to patients. Remember, his Cancer Care Ontario experts are sure that PET CT is basically unproven technology and shouldn't be offered for the indications I'm talking about here. So my question directly to you, Dr. Hoskins, and the Cancer Care Ontario people watching this video, is that just what would be the benefit of this compulsory high radiation dose CT with contrast to this patient? So now the other thing to remember about this, even if there were no other findings on the PET CT, the point is that had we have had the PET CT before the biopsy was done, the radiologist then would have known where to put that needle and had the highest possible chance of getting a successful result, and the physicians then make proper treatment decisions for this patient. So this is the case 3 now in my series, and this is a 76-year-old female with a CT showing probable right lung cancer and spread into the mediastinum, or the middle of the chest. There's the brain, uptake of sugar, and all this shouldn't be here. This is the heart, and this is what they're talking about, the right chest and the mediastinum. Now, we can see they've biopsied this, but there's no scar tissue here. This is all tumor, so not surprisingly, they get a positive result. But look at this. This little finding right here, this happens to be through, again, the patient, left shoulder, right shoulder. That's right at the base of their neck, above their clavicle on the right side. We actually call this special area Virchow's node area because this is a very common spot for cancers from the lungs and the abdomen to spread. And this site, obviously, as you might guess, is going to be much easier and safer to biopsy. So just going over that, the patient, if we had the PET first before we did the biopsy, then you could palpate this area. If you couldn't feel it, then you could just use an ultrasound, and then you could easily obtain a biopsy of this area with virtually no risk to the patient, and of course just a huge benefit for the patient, minimal discomfort and stress to this 76-year-old female who's already worried about having cancer. But I assure you, Dr. Wynne, Dr. Hoskins, and the Ontario Liberals do not want this patient, or any patients like her, to have access to yet another critical use for PET scanning in the world. Excuse me. So this is, again, let's just look at this again. Now, I don't know how many notice this, but this is the bladder here. But what's this little spot down here? Well, this turns out to be a spread of cancer to her pelvic bone. This is called the ischial bone. That's the left hip and the right hip. So we've taken a slice through that area. But this now shows that this patient has metastasis in the pelvic bone here. This is stage 4 and a poor prognosis for this patient. But remember, there's extra information here as well. If you saw the first video, there is something called the SUV max, or the standardized uptake value max, of 13.5. And this simply tells us that this is a very aggressive cancer, no matter what the stage is. So she will die from this cancer and can only be offered what is called palliative therapy, in the hopes that we could prolong her life as long as possible. Now, in any civilized medical jurisdiction in the world where PET is routinely used, and where the government and people offering PET feel that patients are actually worthy of this kind of test, they'll offer this palliative therapy. The point is, where PET can be used is that we can determine readily whether or not the patient is actually responding to the palliative therapy, and if they are, great, you can continue therapy. But often is the case, they're not. They may actually be worse, and so the patient can make an informed decision in the era of personalized medicine to go for quality of life, stop the therapy, and then spend whatever remaining time she has with her family. But again, Dr. Hoskins and Ms. Wynn and the Ontario Liberals, they do not want her to have access to yet another use of PET. Now, so here we are, Dr. Hoskins' agenda for our lung cancer patients, our 2-part video. I just want to remind you that up to 90% of OHIP-funded lung scans for lung nodules and lung cancer forced on physicians in Ontario by Cancer Care Ontario standards, along with their colleagues at McMaster Evidence-Based School of Medicine, and that these indications are the exact opposite of the entire world expert body of opinion. And now, having seen this video, you may be getting some ideas just as to why there's been so much condemnation of the Ontario government and their physicians, and why the rest of the world makes this available when they feel their patients are actually worth this. So remember, social media gives us the power to finally end the Ontario Liberals' agenda directed squarely at our patients. We need to make this a key election issue. If we don't, nothing's going to change for Ontario's patients. So in my next video, I'm going to have a little heart-to-heart chat with Dr. Eric Hoskins, our Liberal Minister of Health. Thanks for paying, if I can get this out to as many people as possible, and hopefully we can make this happen. Thank you.